Hello dear students in the 5th stage of Faculty of Medicine in Jaber bin Hayyan Medical University, and welcome to our 5th lecture that is about hepatitis. In this lecture and in the coming one, we will discuss hepatitis and we will take 2 examples of it, and finally we will discuss the acute liver failure. But for this lecture we will review the outlines. Firstly, the definition of hepatitis should be done and the classification should be followed. Viral hepatitis, it is of the important subject to focus on, and for the rest of the lecture we will talk about hepatitis A infection regarding its pathogenesis, diagnosis and management, and prevention and control. Firstly, we have to define hepatitis. So from its name, hepatitis is a term for inflammatory disease of the liver. The hepatitis is grossly subdivided into infectious and non-infectious causes, and they are characterized by a wide of varieties of clinical and histologic manifestations, and according to these manifestations the hepatitis could range from mild and self-limited to severe and progressive form leading to liver failure, cirrhosis, or hepatocellular carcinoma. The question is, what happens in hepatitis? As we say, it is inflammation of the liver cell. So the liver typically has a similar response to any inflammatory injury, with some differences peculiar to the nature of the histology of the liver. So the mechanism of hepatitis could be either direct toxin-induced necrosis of the liver cell, like what happened in a drug-induced hepatitis, or it may be due to immune-mediated damage of the hepatocyte, like what happened in viral hepatitis. And the area that involved in the damage, it could be mostly on the hepatocellular cell death or necrosis, or it may affect primarily the bile duct leading to bile flow obstruction, or what's called the cholestasis, or sometimes it may be of both hepatocellular necrosis and cholestasis. Now, the liver function is usually preserved even though there is a destruction and necrosis of the liver cell, and the liver function will not be affected or compromised, and the signs of liver impairment not appear until most of hepatic cells are destroyed in the necrotic process. Hepatitis can be manifested clinically, and this is another classification into either acute or chronic. So the hepatitis classified infectious and non-infectious, and acute and chronic, and according to the area of the damage, to intrahepatic and posthepatic or cholestatic. Now, acute hepatitis. From the term we talk about acute, so the matter is related to the time limit, and in most of the conditions the difference between acute and the chronic problem is about 2 weeks if it's more than or less. But in acute hepatitis or in hepatitis, the time limit to make the division or classification of hepatitis is 6 months. So for acute hepatitis, it is the hepatitis that lasts for less than 6 months, and it can resolve on its own, so it could be self-limited, or it may progress to chronic hepatitis, or sometimes rarely result in acute liver failure. Now, the acute hepatitis causes could be infectious or non-infectious. You remember the gross classification or division of the hepatitis into infectious and non-infectious, so the same rule will be followed in acute hepatitis. In infectious, the most common causes is the viral hepatitis due to the hepatotropic virus as a group, that is A, B, C, D, and D usually come with the hepatitis B infection, and finally hepatitis E. Other viruses that cause acute hepatitis are cytomegalovirus and Epstein-Barr virus. The non-infectious causes of the acute hepatitis, it carry a long list of hereditary, genetic, or metabolic diseases. So it could be hepatorenal tyrosinemia, mitochondrial hepatopathy, fatty acid oxidation disorders, alpha-1 antitrypsin deficiency, Wilson disease, polyglandular syndrome type 1, or it could be autoimmune hepatitis or drug-induced hepatitis. Now the second type of hepatitis is the chronic hepatitis, and now you know it is the hepatitis that lasted more than 6 months. And here there is no self-limiting end for the problem or resolve on its own, as we say. So it can progress to cirrhosis, liver failure, and hepatocellular carcinoma, although this is rare in children. But in a chronic hepatitis, clinically the symptom may be absent or may develop insidiously in most of the cases. And again, the causes of hepatitis will follow the classification into infectious and non-infectious. In infectious causes, we will put the group of the hepatotropic hepatitis viruses, but we will exclude hepatitis A and E. And cytomegalovirus and Epstein-Barr virus is still present as causes for infectious chronic hepatitis. While the non-infectious causes, the same list will be, and we will add to it cystic fibrosis and celiac disease and non-alcoholic steatohepatitis. Now the viral hepatitis, which is the most common and most important part of the hepatitis, whether it is acute or chronic. Viral hepatitis is the most common cause, and it accounts for about 72% of the acute hepatitis specifically. And the most common cause of the viral hepatitis are 5 unrelated heterogeneous hepatotropic viruses causing hepatitis. They are A, B, C, and D that come with B and E. So these group of viruses are, as I say, are heterogeneous and belong to different families of the viruses, and their genetic material also differ, and the route of a transmission and the nature of the disease, the cause, the complication, and the management, all of these are differ. The only one thing that make these group of viruses together is its targeting on the affected organ, which is the liver. That's why they call hepatitis viruses. Now we have 5 main types, as we say, and in this picture it focuses on the route of a transmission of the virus to cause hepatitis, and as you see here, it is different from the fecal, oral, to blood, or to the food or infected body fluids. Not just in the route of transmission or the way of contraction of the infection, but as I say, in the genetic material and structure of these viruses are also differed. So all these viruses are RNA virus, except for the hepatitis B virus, which is DNA, and for the hepatitis D virus, it's called delta virus or incomplete RNA virus that needs the hepatitis B surface antigen to cause the infection and hepatitis. The viruses could be double-stranded or single-stranded, enveloped or non-enveloped, and these are the major differences of the structure of these viruses. Epidemiologically, in 2013, about 1.4 to 1.5 million died from viral hepatitis, and most deaths were due to hepatitis B virus and hepatitis D virus infection. and the most area affected in the world was East Asia. You know, East Asia now is the origin and the land of most of the viral diseases. So according to WHO, as you see here, the most deaths are due to the hepatitis B and C, and hepatitis A and E constitute just about 5% of the causes of death due to hepatitis. Now we will discuss the pathophysiology of viral hepatitis in general. These viruses did not or does not directly cause apoptosis or cell damage, and the infection of liver activate the innate and adaptive arms of the immune system, leading to an inflammatory response which causes cellular damage and death. So the presence of the virus itself, it is not a toxic or causing necrosis of the cells, but the immune mediated process that happened due to the response to the presence of these viruses will initiate the cellular damage and death, and of course will initiate the clinical manifestation of the disease. So the infection can either lead to a clearance, which means the acute disease, clearance of the virus, or persistence of the virus, which means the chronic disease. And this will happen according to the three factors. It depends on three factors. First is the strength of the immune response of the body, and the second is the type of immune cell involved in the immune response, and third is the ability of the viruses to evade the body defense. This will affect if the viral infection due to hepatitis viruses it will be acute or chronic. So the chronic presence of the virus, if it will be chronic presence of the virus within the cell result in multiple ways of inflammation, injury, and wound healing, and as a chronic inflammatory process, and this is over time will lead to scarring of the fibrosis and culminate in hepatocellular carcinoma, although as we say it is rare in children. And of course, because we say the strength of the immune response will be one of the determinant of the nature of the viral presence in the liver, so the individuals with an impaired immune response, they are at a greater risk for developing a chronic infection. Now this table summarizes the IDs of these group of viruses regarding its type. So you can see here the different families of these virus and the different in the nucleic acid nature, whether DNA or RNA. The transmission route also differ from fecal, oral to parenteral. The incubation period is also differ. The diagnostic test, the mortality rate, it is the lowest in hepatitis A virus and highest in hepatitis D and B, as you see here, and the carrier state, if it is a chronic or acute or can carry the virus for long times. The availability of vaccine is also differ, and all vaccines are present for the these group of viruses except for hepatitis C virus. This is unfortunately, and the treatment will differ from non-unsupportive to a specific antiviral treatment or interferon. Now, from now to the rest of the lecture will be about the hepatitis A virus infection. So, what we have to know about hepatitis A virus infection, of course, all and everything about it we should know, and this will be in focusing on the pediatric viral hepatitis, but the informations given here can be a base for the viral hepatitis A even in the adult age group. So firstly, we have to know the ID of the hepatitis A virus. It is a hepatovirus within the Picornaviridae family. It is a non-enveloped, single-stranded RNA virus, and it is one of the most common cause of acute hepatitis, and it comprises about 2/3 of the acute viral hepatitis or acute hepatitis in general is due to hepatitis A virus. And this is firstly isolated by an American virologist, Dr. Robert Purcell, in 1973. And the human appear to be the only reservoir for the viruses, so there is no intermediate host. Now, this is the shape of the hepatitis A virus. It is called icosahedral shape or multiple polygonal faces. And this is the coat or shell of the virus, which is the capsid. This is not an envelope, but this is coating the genetic material, the genome of the virus RNA, which is single-stranded, as you see. And here is what is called the VPG, or the virus protein-linked genome, which found at the end 5 of the RNA virus, and it's responsible for the initiation of the replication of the virus and synthesis of the RNA material. And this is the picture of the internal structure of the virus. So this is a hexagonal shape. These are the capsid, and this is the single-stranded RNA, the VPG, and each capsid is composed of 4 viral polypeptides, and the size or diameter of this virus is about 27 to 28 nanometers. And this is how the hepatitis A virus appear under electron microscope. Now I give you 2 facts, or 1 fact in 2 words, 2 ways. Hepatitis A virus infection never result in chronic hepatitis. I will repeat in another way that hepatitis A virus causes only acute disease. So no carrier state and no chronicity, never in viral hepatitis due to hepatitis A virus infection. The clinical symptoms of the hepatitis A virus infection range from mild and asymptomatic to severe and fulminant hepatitis, especially when the infection is contracted as an adult. Now, what about the epidemiology of the viral hepatitis A? We say it is the most common cause, or one of the most common cause of acute hepatitis, and especially the viral hepatitis. So it is really endemic hepatitis disease, and found throughout the world, particularly in the resource poor regions like in our country. It occurs in both epidemic and sporadic fashions, and it is the predominant in children of 15 to 14 years of age, with a rare infection for infants, and it also decreases in prevalence or in incidence in age more than 14 years. But the important thing that the infected children at this age group is have little to no apparent clinical illness, in contrast to adults in whom more than 80% are symptomatic if infected. So the incidence in the adult is less, but the symptoms is more severe. While in the pediatric age group, it is high incidence, but the symptoms is may be mild or even absent. So in 2005, the WHO estimated that about 126 million cases of infection occurred worldwide, and resulting in death of about 35,000 persons. And you see the huge number of the infection cases and the death, and you may make a comparison with what happened due to COVID-19 pandemic nowadays. The mortality from fulminant hepatic failure, it increases with increasing in age despite decreased prevalence of disease as age increase. We say the most age affected is the pediatric age group, and specifically the 5 to 14 years, but we say the symptoms is less severe, so the progression to the fulminant hepatic failure or the mortality that's subsequent to it is decreased in this age group, while in the older individuals or in the adult the prevalence decrease, but the symptoms is severe, and the progression to fulminant hepatic failure and subsequent death is increased. Most of infections occur in community, and we will know why, but hospital-acquired cases have been reported. The mode of a transmission of the virus, and the main mode of a transmission is the fecal-oral route from contaminated uncooked food or from water supplies, including by the food handlers. So it's mainly a foodborne disease. Sporadic cases usually result from contact with uninfected individuals. And the transmission, the question now is, can be transmitted parenterally? Yes, it can be transmitted parenterally by the blood products like clotting factors, and this can be obtained in a certain period of the disease, which is called the viremic phase, where there is a lot of viruses shedding in the presence in the blood, but this is a rare event. Again, the fecal-oral route is the main route for the infection of this virus. And these are the food that's most associated with hepatitis A virus, and the most common of these are the shellfish and the raw vegetables and salads. This is causing the epidemic or outbreak pattern of infection of hepatitis A virus, of course, not the sporadic fashion. Now this map shows the distribution of the virus throughout the world, and as you see here, all the world are affected, but the prevalence is differ from certain areas to another. And for our region, we live here in the Middle East, so we are in the high endemic area with high prevalence in hepatitis A virus. And what this means? This is mean that in developing countries like us with poor sanitary conditions and hygienic practices, most children, and about 90% of them, have been infected with hepatitis A virus before the age of 10 years, and this is mean more than 90% of children by age of 10 years have immunity from the infection with the virus. While the intermediate regions here in the green color, about more than 50% of the people here have immunity by the age of 15 years. While in the low areas like in North America, West Europe and Australia, about 50% of them have immunity by the age of 30 years, and in Northern Europe, like in Scandinavian countries, about which is very low in the prevalence of the hepatitis virus, less than 50% of them will have immunity by the age of 30. Specific populations at risk, they are for developing the hepatitis A virus, are person-to-person transmission that observed in most cases, and the travelers to endemic regions regarded as a risk factor, individuals with the clotting disorders who have received the clotting factors, and history of chronic liver disease where co-infection with hepatitis A virus can lead to fulminant hepatitis, and of course intravenous drug user, although this is rare. And this is show the distribution of the high risk factor and the way of contracting of the viruses from the daycare, from the household or sexual contacts, from the common source outbreak or international travelers or intravenous drug users, or maybe due to unknown causes. Now, what about the pathogenesis of the hepatitis A virus infection? Following an ingestion, the virus replicates within the GIT. And before a virus replicates in the GIT, it may replicate in the oropharynx, and it passes across the blood. It's absorbed by the blood through the intestine. It will pass to the liver, where the main replication, the major replication of the virus will happen inside the hepatocyte. So this will lead to entry into the liver via the portal venous system. And although after the replication in the liver, so now we know the replication can happen in the liver and can happen in the GIT starting from oropharynx. After replication in the liver, there will be a period of viremia, brief viremia, and it will shed in the bile, excreted in the bile, and again go through the intestine to be excreted in the stool or reabsorbed. So the cellular immune response of the body due to the presence of the virus in the liver cell, it will affect, or it will determine the clinical manifestation of the disease and its control. So although the virus, as we say, appear to be non-cytopathic to the hepatocyte, but the inflammation will ensue or will start, and there is no chronic liver disease in hepatitis A virus. The development of an immunologic response to infection within the liver is accompanied by predominantly portal and periportal lymphocytic infiltration and a varying degree of necrosis that happened, as we say, from the immune response. And it is believed that hepatocyte injury is secondary to the host immunologic response, not to the direct effect of the virus on the hepatic cell. And this is supported by the lack of cytotoxic activity in tissue culture and a correlation between the immunologic response and the manifestation of the hepatocyte injury. And following the incubation period, a large amount of virus is shed in the stool. The incubation period is about 15 to 40 to 50 days. Now we will talk about the clinical manifestation, and as I say, the clinical manifestation is determined according to the immune response of the body to the presence of the virus inside the hepatocyte, and it is not due to the direct effect of the virus on the liver cell. The nature of the disease is a self-limited infection of the liver, and the average incubation period is about 30 days, and it is about 15 to 40 to 50 days. And the non-specific symptoms prior to jaundice appear by 5 to 10 days, and these non-specific symptoms we will talk about the percentage of the affected or symptomatic patient. 2/3 of the children are asymptomatic, and 2/3 of the symptomatic children are anicteric, not manifested with jaundice. And the symptomatic infection is rarely observed among infants and children less than 6 years of age. And in those affected, less than 10% of them have jaundice. Anicteric infection is 17 times more common than icteric infection in patients less than 3 years. And the presenting symptoms, now we can see this. So less than 6 years, most of them are asymptomatic, and about half of them between the 6 to 12 years are symptomatic, and not jaundice, as you see here. And the jaundice is more common in the adult persons. So the clinical feature or the symptoms of hepatitis, it is in the non-specific symptoms, and it may be mild and resembling that happened in gastroenteritis in form of anorexia or reduced appetite, fever, vomiting and nausea, and headache, and abdominal pain and pain in the right side of the abdomen, and digestive disorders of diarrhea. So that's why we say like gastroenteritis. And it may be presented with weakness and fatigue, jaundice, dark urine and pale poop, and it may cause joint pain. The non-specific symptoms, as we say, this is dark urine precedes the jaundice, which peaks in 1 to 2 weeks and then begins to subside. So 1 to 2 weeks is the period of symptomatology in hepatitis A virus infection. We say the stool may become light or clay colored with dark urine, and the clinical improvement can occur as the jaundice develop. A tender hepatomegaly and jaundice are typically present. So when there is jaundice, always there is a tender hepatomegaly. This is the meaning. And splenomegaly is variable. So as you see here, the frank jaundice of the sclera in patients with acute hepatitis due to hepatitis A virus infection. Now, how we can diagnose patients with hepatitis? Firstly, you will start with history and examination. And the history should be focusing on important questions about direct exposure to a previously jaundiced individual because of the fecal oral route or direct contact as human to human to cause the jaundice, and consumption of seafood, contaminated water or fruits or vegetables, raw vegetables like in salads. This is important. The question should be asked in feeding history. And history of high risk exposure to the disease like a chronic disease or using of clotting factors or traveler to endemic area. The examination will be for the signs of icterus like jaundice, tender hepatomegaly, and if there is splenomegaly, and of course for the fever. Then after that we will go to investigation, and will be about the lab finding about the serology and about the liver function. So there will be an elevation of the liver enzymes, that is aminotransferase, AST and ALT, and total serum bilirubin, of course. And although unusual, but the liver function may be affected by hypoalbuminemia, hypoglycemia, and marked increase of the prothrombin time, and this is indicator of liver impairment, and it's very important and significant, although it is rare, unusual. And the serology to the presence of the virus is by the anti-hepatitis A virus IgM antibody, and if it is positive, this is diagnostic. The potential negative IgM result may found in some children in the early phases of the disease. So if it is negative, this does not exclude viral hepatitis due to A if the patient presented earlier. Antibodies appear within 5 to 10 days after symptoms onset and may persist for up to 4 months. So this is very important in a clinical practice when you examine a patient that has developed the jaundice or the symptoms in general just in a few days, and you send him for the anti-HIV IgM and it is negative. Again, this is not exclude, and you may have to repeat the test after 5 to 10 days. This is about the IgM, and IgG is important because it persists after recovery, and we will know what is mean the presence of the positive IgG anti-HIV. Percutaneous liver biopsy is rarely indicated. No need to do that, and if we do it, so we will find a balloon cell and acidophilic bodies, which are a characteristic histologic findings in hepatitis A virus infection. Now, how we deal with the results and how we interpret the results of serology. So if we suspect the patient has hepatitis A virus, send him for IgM, anti-HIV. If it is positive, this is mean there is acute infection, of course. But what is if this is negative? If this is negative, it may be, as we say, early in the course of disease, especially a few days after the symptoms appear, or we have to do a total anti-HIV. That's mean IgM and IgG. So if we found the IgG positive, this is mean the patient is immune to the virus, and the immune may come from the past infection or from immunization. That's mean vaccination. But of course, if there is no IgG and no IgM, this is mean the patient didn't contracting the infection. So this is the approach to diagnose hepatitis A virus infection. And now these are the interpretations of the serology. So if the patient has a positive IgM, this is either mean acute or recent infection or post-vaccination. But if the patient has hepatitis virus A IgG antibody positive, this is mean immunity from past infection or vaccination. If both of them are negative, this is mean no infection, or as we say, early in the disease. And if they are positive for IgM and IgG, so this is mean acute or recent or past infection. And if we want to differentiate, this requires to do a separate IgM assay. And this diagram shows the hepatitis A time course of infection. This is in weeks. So as you see here, the first 2 weeks, it is the average of the incubation period. Here is no symptoms and no serology and no liver function affection. But since the 2 weeks of the disease, the virus start to shed in the feces, and the viremia, this means presence of the virus in the blood, this is lasts for about the mid of the 5th week, while the virus shed lasts for about the 7 weeks, and at the end of the or mid of the 4th week, the liver function affected in form of elevated transaminase. The symptoms start after the 4 weeks, and especially the jaundice, and it may last about 2 weeks or 3 weeks, as you see here. While the IgM, which is indicator of the infection, start to increase from the end of the 4th week and peak about the mid of the 6th week, then start to decline. While the IgG elevated later on, about after the beginning of the 4th week, and reach to the peak at about the 10 week or 11 week, then it will enter in a steady state and be positive always, reflecting the immune status of the patient either from past infection or from vaccination. Now, what are the differential diagnoses of the hepatitis A virus? Pancreatitis, it may be. Infectious mononucleosis, it is Epstein-Barr virus. Leptospirosis, drug-induced hepatitis. Wilson disease, autoimmune hepatitis, infection with other hepatitis viruses like CMV or cytomegalovirus. Now, what about the treatment of the hepatitis A virus infection? Firstly, no available antiviral treatment for the infection, and the management is largely supportive for those in need. Bed rest is reasonable for the child who appears ill, and sedatives and corticosteroid should be avoided because it affects on the liver function. During the icteric phase, that means the presence of jaundice, lower fat food may diminish the GI symptoms but do not affect the overall outcome. And this is the question, the routine question we asked by the parents, and we advise them that during the 1 to 2 weeks avoid the fatty meals because it will alleviate the symptoms, and we encourage them to take a high sugar or high carbohydrate food to enhance the function and to relieve the symptoms, but of course it didn't affect the outcome of the disease. Drugs and elective surgery should be avoided. So that's why during the period of jaundice and the first 2 weeks of the symptoms of clinical symptoms of the disease, we avoid to prescribe any medication. Of course, no antibiotics, and even the antipyretics, we avoid it because it may have a direct hepatotoxic effect on the liver, and he is an inflammatory response due to the immune response of the body. Hospitalization, may we need it, and recommended for the patients with coagulopathy, encephalopathy, or severe vomiting. Coagulopathy, encephalopathy, this is significant because this indicates a progression of the disease to affect the liver function. So the admission for this patient is preferable and advisable to follow up them. Now, what about the prevention? Prevention of the disease and control of the infected individuals with disease. Firstly, we will control of the infected individuals and prevent the spread of infection to the other. How? Isolation of the patient during initial phases of illness is indicated. And how is that? This is by isolation of all equipment used by the virus. By the individual. You know, the virus is transmitted by the fecal oral route. So the spoons, the dishes, the glasses, and the personal uses of the individuals affected should be isolated from other in the same family. And careful handling of stool is important, diapers, and other fecal stained clothing for 1 week after appearance of the jaundice, because in this period the shedding of the virus in the stool is at the maximum phase and may contract the infection by this way. This is very important. How we prevent the virus infection for the healthy individual? Now this is the isolation for the infected individual, and for the prevention of the for the effect. Now, passive immunization is important, and this is recommended for with immunoglobulin 0.2 ml per kg IM for exposed susceptible person. Those exposed to infected individuals who are less than 12 months old or more than 14 years of age. So, if there is an idea that the viral hepatitis in children is not contagious and cannot be transmitted to adult, this is wrong. Those who are more than 40 years of age and exposed to hepatitis A virus may be susceptible to contract the infection, so passive immunization is important. And of course, for immunocompromised patient or who has chronic liver disease, this is regarded, as a high risk group for developing hepatitis A virus. And in those, if the infection happen, we may not expect the self-limiting end of it. It may progress to fulminant hepatic failure. But of course, we didn't have in our practice a passive immunization for patients with hepatitis A virus. And of course, the vaccine is not available, but we have to know it. Hepatitis A vaccine is recommended following exposure for individuals from 12 months to 14 years age old. And the vaccine is routinely administered to children in the United States as 2 doses series starting at age 12 to 18 months. Unfortunately, we didn't have, although we are a high endemic area with high prevalence of hepatitis, but the vaccine for hepatitis A virus is not included in the expanded program of immunization in our country. All children with more than 12 months of age with a chronic liver disease, for whatever the cause, should receive 2 doses of hepatitis A virus infection vaccine 6 months apart. And you have to know that lifelong immunity to HIV follows infection. So, now 3 important facts you have to focus on. Hepatitis A virus infection didn't or never cause a chronic and cause only acute hepatitis, and if the patient contract the infection with this virus, there will be a lifelong immunity to it. That's why we say when the IgG positive in any patient, in any person, this means either immunity to a previous infection or due to vaccination in countries apply the routine vaccination for every person. And as you see here, the effect of the vaccination to reduce the incidence or prevalence of the hepatitis A virus infection, and this is started to be applied in the United States since 1995, and it make major differences in the prevalence ratio in them. Just to remind you how we prevent the hepatitis A virus infection, because it is a fecal oral route mainly, so the frequent and vigorous and real hand washing is very important, and the proper toileting, and of course the well cooking of the food, and concentrating on the healthy food for the liver and avoiding the harmful drinks of the liver will result in a good health of the liver, and if the patient contracts the infection, it will pass it safely. Now, what about the prognosis of the acute hepatitis due to hepatitis A virus infection? Fortunately, 99% of children recover without sequelae. We talk about children, of course. But increased risk of death in those with a chronic liver disease. In rare cases, there may be an acute liver failure or fulminant hepatitis, and the death may occur within days to weeks, and requires evaluation for liver transplantation, otherwise this is the eventual outcome. Incomplete resolution can happen and can cause a prolonged hepatitis, but of course not chronic, because it will resolve, or it should resolve before 6 months of the duration. Rare cases, the patient may have extra hepatic problems, like hematologic problems, autoimmune hemolytic, this is rarely autoimmune hemolytic anemia, aplastic anemia, and pure red cell aplasia. Or it may have a pleural and pericardial effusion, and there may be acute kidney injury or pancreatitis, and acute reactive arthritis have been reported following acute infectious hepatitis, but this is, as I say, rare. After resolution of the disease, maybe relapsing of the symptoms? Yes, the relapsing may happen in about 10 to 15 or to 20% of the cases, and this has happened after 6 to 10 weeks of apparent resolution. But of course, this does not mean the patient has a carrier state, and this does not mean the chronicity of the disease, because everything will disappear before 6 months, as in 99% of the children, or rarely may evolve to the acute liver failure. Now this diagram will show the outcome of. So as we say, in more than 70% of children less than 6 years of age, it is asymptomatic, and the spontaneous recovery is the outcome. And in those adult, more than 70% of them are symptomatic. And for these symptomatic acute hepatitis, 10 to 20% or 15% there is a relapsing hepatitis or prolonged cholestasis and resolved during the acute period. And in 99% of them there will be spontaneous recovery, and in less than 1% there will be acute liver failure. And the acute liver failure, it may end with a spontaneous recovery in about 55%, or in about 35% it need liver transplantation, or it may lead to death in about 10% if there is no thing interfere with. For symptomatic percent and less than 10%, as I say, or even more rare than this, or more or less than this, there is the extra hepatic complication, as I mentioned, like the hematological problem, pleural and pericardial effusion, acute kidney injury, pancreatitis, and acute reactive arthritis, and they may lead to eventual end of death. But remember, more than 99%, whether asymptomatic or symptomatic, and with spontaneous recovery, and less than 1% with acute liver failure. Now we can summarize hepatitis A in the major PowerPoints and outlines. Route of transmission is orophycal route. The spread is easily, it is self-limiting, and the vaccine preventable in the countries applied it, and the disease carry good prognosis, and the prevention in addition to the vaccine is related to good sanitation and good hygiene, so the infection is related to poor sanitation and poor hygiene. That's why it is high prevalence in our region. Again, we insist to encourage the proper hand washing to prevent the spread of hepatitis A virus infection, as well for the COVID-19 and any other contagious or infectious diseases. And now we are reaching to the end of our lecture. I hope it was useful to you, and thank you for your listening.